Well, good morning, everybody. To those of us who may not have made my acquaintance so far, my name is Nicholas Saul, and I'm doing this because I'm the co-director for Arts and Humanities in the IAS. It's my pleasure today to introduce Armando D'Agostino. Our practice, of course, for seminars is that we don't give lengthy introductions to our contributors because time, of course, is of the essence here. I'll just say that Armando is a very distinguished but also experienced theoretician and practitioner from Milano, and that he has one of the best titles I've heard in recent years, From Dream to Sleep, Oscillatory Activity in Psychosis. Over to you, Armando. You have half an hour or so, and then we'll have some questions.
Okay, thank you very much for the introduction. My seminar title is From Dreams to Sleep, Oscillatory Activity and Psychosis. Although, since giving this title, I did decide that I would try to focus more on the dreaming phenomenological side, because I am attempting to tackle a question of how to develop this type of research at the moment. And I think this is something that this fellowship is helping me for very much. And I hope it's a good contribution to the team as a whole of this Threshold Worlds project. And I will just briefly go through the focus of this seminar. And my interest has been over the past 10 years, I would say, to try to somehow frame the relationship between dreaming and psychosis and psychotic experiences. And I've done so first by working on the phenomenological aspects that I thought could bridge these two experiences from an experimental point of view, and then moved to study sleep oscillatory activity in psychotic patients, and trying to sort of close a circle now, because this is the type of complexity that we have to face when we tackle complex mental experiences from a clinical but also neurobiological research point of view. Of course, it's very difficult to completely frame a complex mental state within any form of brain imaging or, for example, EEG topography of the mental state. And this is the reason why, as I moved towards an analysis of the narrative text that was emerging from patients' dream experiences and waking life experiences towards sleep EEG topographies, I actually put the dream psychosis analogy aside and decided to focus for a while on what I could gather from the most up-to-date research on what we understand of sleep in these subjects. And now I'm trying to work my way back to the mental experiences and understand which could be the better way to address what I see as a very fundamental sort of track for research that has found very many difficulties over the years. It's been of interest for researchers ever since we have began to look into the sleep of patients in the 1970s, and the topic of this analogy between dreaming and psychosis has been so difficult to frame, and some researchers decided to leave it aside. And this is something that is actually every now and then returns in the literature. And I decided I would start this talk with a very recent paper from Francesca Sicleri, who's an Italian colleague working in Switzerland, and she's possibly the researcher who has published the most up-to-date neurobiological framework for dream biology. And this is a study, several studies that have emerged from Giulia Tononi's lab, and where she was working in Madison, where they developed a multiple awakening paradigm to address the underlying neurophysiology of the dreaming brain. And they developed this idea of the existence of a posterior cortical hot zone that tends to light up when we experience dreams. And this has been has pushed the field quite forward in one direction, that is to confirm the distance from the original idea that dreaming only occurred in the REM sleep. And this group has clearly shown that dream experiences, conscious experiences, can emerge from sleep in very different moments during the night, in very different stages of sleep. But what occurs in the brain while we are dreaming is something that is possibly suggestive of an emergence of a conscious experience that is common across the different stages. And this is not too surprising, because when we speak of sleep stages, we're speaking of something that is of course, in terms of sleep macroarchitecture, which is the shifting from wakefulness to non-REM sleep, to different stages of non-REM sleep, and then to REM sleep, is of course something that is a level of analysis that was what our instruments could give us when the sleep was first assessed with a polysomnography. So, of course, as we progress with research, we might even go into a debate over the appropriateness of the distinction that we make in terms of macroarchitecture of sleep, because we now know that, for example, different brain regions can do different things during different stages of sleep. And we have begun to discuss topics such as what is now called local sleep, which suggests that we might have, or that we actually do have, islands of sleep during wakefulness, and reciprocally islands of wakefulness during different stages of sleep. And this is something that actually goes in the direction of showing that possibly we have a limitation at the moment in the way we describe the stages of sleep, if we really want to map the conscious experience of dreaming onto an underlying neurophysiology. So I thought it would be interesting to start from this researcher, because this is another take on the topic of the analogy between dreaming and psychosis. And you see, according to Francesca, contrary to waking experience, most dream contents do not bear any relation to the environment because of the sensory and motor disconnection that is inherent to sleep. And instead, dreams are internally generated experiences, and by definitions, they are therefore hallucinations. Of course, when we speak of hallucinations in psychopathology, we have a second aspect beyond the internally generated experience to actually define the hallucinations, which is the lack of insight over the internal origin. These are the two aspects that we really want to place together when we want to describe, define a hallucination. Otherwise, we would use terms such as pseudo hallucinations, or to some extent, we would go into a definition of something that is called an illusion. If we have different grades and different shades of insight that the person can have over the internal origin. To put it simply, if I experience an object which is not in the environment, or if I experience something that is, if I experience it visually, or if I experience a sound that is not an environment, such as a voice, or if I sense across the olfactory domain a smell that is not present, then of course I do have this perception, an altered perception. But to be really defined as hallucination, I must be unaware that it is internally generated. Otherwise, I would be in a condition in which I am able to describe it as something that is not experienced in the environment. And this we will see is very typically observed in schizophrenic psychosis, and less observed in other forms of psychosis. And according to these authors, dreams are also akin to a delusional state, because with the rare exception of lucid dreaming, dreamers typically take the dream experience to be real, not realizing that they're in a bed, dreaming, despite the major contextual and temporal incongruencies that characterize some dreams. So if you eliminate the concept of being in bed from this sentence, and you only describe that a subject is not realizing despite their experience, despite the major contextual and temporal incongruencies that characterize the experience, well, of course, you have a very clear description of several of the subjective experience that occur in patients with psychosis during wakefulness. And again, the important aspect is the construction of a belief, and associated with the construction of a belief, the lack of insight over the internal origin of the belief and the incongruence with the external context. So what are the evidences that we have that allow us to say that dreaming and psychosis share some aspects that can be neurobiologically or phenomenologically be associated beyond this descriptive aspect? So how can we experimentally attempt to confirm this observation that is remains on an observational level and defines it, and it's very difficult to confirm experimentally? Well, one of the things that the authors address in their paper is the relationship with dream experiences and medications. We have a lot of medications that can have an effect on the central nervous system, a lot of medications that are not used for the to address neurological or psychiatric problems, such as antihypertensive, anti-infectious drugs. We have several anti-allergic and anti-inflammatory drugs that can pass the blood-brain barrier and have an effect on the central nervous system. Well, not all of these have an effect on the sleep-wake rhythm or specific aspects of sleep physiology, and not all have an effect on dreaming. Well, of great interest to us is that drugs that stimulate the dopaminergic system very directly, such as pramipexole or levodopa, which are drugs that are typically used in neurological motor disorders such as Parkinson's disease, these are drugs that have a net effect of increasing dopaminergic tone. And if you see across all of the drugs that are described here that have an effect on the central nervous system, only pramipexole and levodopa have this very simple net dopaminergic increasing effect on the central nervous system. And what are the effects that they have on dreaming? They intensify the vividity of dreams, and they intensify the experience of dreaming, and they can be associated, and this is especially true for levodopa, with nightmares. Well, another interesting aspect that these drugs have is that in waking patients, they can give waking hallucinations. So patients with Parkinson's disease who have never previously experienced hallucinatory percepts can have hallucinatory experiences due to levodopa dosing. And this is also true for pramipexole. And they can also have, more rarely, but this can occur, they can also have delusional experience. So we can have a form of levodopa psychosis. So on one hand, we have the possibility that these drugs change the dream experience and intensify the vividity of dreams and intensify the experience of nightmares. On the other, during wakefulness, they can induce a form of psychosis. So we have a very direct effect of these drugs, but of course, this remains an indirect form of evidence on the association between dreaming and psychosis. The work we did was on this was focused on the narrative experience of dreams and waking experiences in subjects, and we observed that the ability to organize narrative experience in psychotic subjects independent of their underlying diagnosis. And this you can see here schizophrenic patients in the compared to controls in the blue plot, and bipolar disorder patients compared to controls in the green plot. And these are all subjects who are actively psychotic. So they are subjects that are hospitalized due to their psychosis, and they have a high level of what we call cognitive bizarreness in their wakefulness. And this is very, very similar to what is observed across wakefulness and dreams across dreams in patients and healthy controlled subjects. So all subjects have a relatively high level of bizarreness in dreams, and this is independent of having a psychotic state or being healthy controlled subjects. Only patients with an acute psychotic state have a high level of cognitive bizarreness. And this is something that we believe is some form of evidence, but of course it has all the limitations that we will see are deflective of the what is called the reportability of the dream experience. So basically, when we are analyzing dream narratives and waking fantasy narratives from patients and from healthy control subjects, we have to somehow accept the limit that what we are working on is not the dream itself, it is not the waking experience itself, but it is only the narrative that the person can give of that experience. And of course, there are many, many evidences, and this is something that other fellows have spoken about in our group, and this is something that is, of course, one of the core aspects that we're debating is the problem with the reportability of the experience. There are many things that suggest that dream experiences are not verbal experiences, and they are not primarily reportable as such. So there are other evidences from brain imaging. This is another indirect evidence, and they are closely related to this concept of insight over the nature of the experience that we have mentioned before. In dreaming and in psychosis alike, we see that we have in both states hallucinations, delusions, bizarre experience, disorganized thought. That is something that is very akin to what we record as a cognitive bizarreness of the experience. We have emotional intensifications, and we have a lack of insight into the current state. So insight in dreaming and insight in psychosis has been associated with activation or deactivation of several brain regions, and these appear to overlap across these two states. And this is, again, not too surprising, because when we look at brain imaging studies, we are looking at something that actually reflects the activity that we are observing in the patients, in the subjects. So if we can recognize a similar form of insight across these two stages, it's not surprising, but it is very important to confirm that we have, for example, hypoactivation of the dorsolateral prefrontal cortex and of the frontopolar cortex and of the superior frontal gyri and medial frontal gyri. And these are all areas that are associated with cognitive processing of and in more generally of the higher functions that are necessary to define the concept of insight. So of one's conscious awareness over the internal origin of the experience. So this is lacking in both dreaming and psychosis, and this seems to be reflected by similar underlying states. So if you look at this type of indirect evidence, why indirect? Because this has not been found in a study that assessed the dream and waking experiences of patients. This is taken from different studies. As you see, the references refer to different numbers, which in the paper implies that there are different types of research done on different subjects. And what we see from the dreaming side is taken from subjects who are healthy subjects who underwent experimental protocols to address the underlying neurobiology of insight, for example, in lucid dream studies. And Martin Dressler, the colleague from Munich, is certainly one of the major experts in this area. And research on psychosis is done on for other reasons, and it's done to maybe with other types of tasks to elicit insight over the patient's experience. And it is very difficult to assess this by directly addressing the problem in patients by studying their underlying brain activity during wakefulness and during dreaming. Why is this so? Because you need large samples of patients, and acutely psychotic subjects are not subjects that have physiological sleep and are not subjects who are able to address long protocols as those that would be required for a long night imaging, brain imaging study. So this is a very complicated matter to address directly through a form of brain scanning technique, such as functional magnetic resonance imaging, for example. And this is one of the major reasons why the research in this area tends to move very slowly, because in general, we tend to ask patients who are relatively stable in their clinical condition to undergo these type of experimental studies. Of course, this is an ethical, absolutely appropriate ethical constraint, and I have nothing against it. But it's important for us to also recognize that if we have a patient who has a diagnosis of schizophrenia, they are not continuously in a psychotic state. And if we are helpful in any way as psychiatrists, the majority of our patients won't be in an actively psychotic state, because they will be medicated and they will be treated for this condition. And this implies that when we are actually asking these patients to sit for a brain scan, for example, we are not observing directly what is occurring in their brain at the time in which the hallucinatory and delusional experience is more intense. We are observing what is some form, I would say, of residue of that experience, and probably what is the underlying pathophysiology of their activity, but not what actually occurs during the acute state. Whereas when we're studying healthy controls during sleep to address their underlying dream experience, then we are actually addressing directly what is occurring in the moment in which the florid hallucinatory and delusional experience of dreaming is at its most. So we have some indirect evidence, but we know that we have key differences across these two states. And first of all, sleep-related perceptions are immersive and largely cut off from reality, whereas hallucinations are discrete and overlaid on veridical perceptions. And this is also true if we discuss this in relationship, for example, to the delusions of patients. Delusions are, of course, very fixed beliefs, but they are continuously in interaction with the external environment, and the patient tends to re-elaborate their delusion and reinforce the delusion on the basis of the external environment. But for example, in the context of a therapeutic relationship, the the delusional experiences, but also the hallucinatory experiences can be somehow kindled, and they can be somehow modified in the psychotherapeutic relationship, for example, with cognitive behavioral interventions. Because these are experiences that occur during wakefulness, and the patient is able to address the experience and make it somehow relational and discuss it with the person that is bringing another type of reality compared to the one that the patient is experiencing. Differently, what happens during sleeping in healthy subjects is that the detachment from the environment is total and the experience is fully immersive. Another difference is that sleep-related perceptions involve only a subset of neural networks implicated in hallucinations, reflecting perceptual signals processed in a functionally and cognitively closed-loop circuit. This is evidence emerging from this review of the authors, and of course what we previously showed was that the insight in the two experiences is something that seems to share overlapping neural circuitry, but in terms of hallucinatory experiences, this is much more difficult to show, and this is of course, the conclusion is that only a subset of neural networks is implicated in sleep-related perceptions and those that we observe in the waking psychosis. And of course, the difference when we address this is that very, very rarely do we have patients who can be studied in terms of their underlying neural circuitry who have such complex multimodal hallucinatory experiences as those that are observed in dreaming. If you are in the dream state, you are hallucinated across at least two domains. Most of the times, the visual domain is most obviously implicated, but also often the auditory domain. But you might also have other forms of hallucinatory domains involved, such as the olfactory system or the more rarely also the touch and taste systems, which are included in the dream experience. Well, if you are a patient who is experiencing a psychosis, this usually occurs across one sensory modality, and this is typically a visual modality if you are in a neurological or organic form of psychosis, or in an auditory modality if you are in a schizophrenic form of psychosis. So, insufficient evidence exists to fully support the notion that the majority of hallucinations depend on REM processes or REM intrusions into waking consciousness. So, immersivity, we said, is the major focus of this difference. Dreams are generally experienced as vividly immersive worlds, whereas psychotic experience can vary considerably. And reportability, and a transition from reportability to experientiality is probably favorable if we really want to frame the object of inquiry. Rather than narrativity, experientiality may be the dominant component of dream states, and this might be a reason why it is somewhat limiting to only study, for example, the cognitive organization of the narrative transcript of the experiences. And we really need new protocols that allow us to access the experientiality of the patient and of the dreamer to address the similarity between these two states. So this is what I'm thinking about thanks to this involvement in this fellowship, and of course, when Alan Hobson described dreaming as a model for madness, he referred to a delirious form of madness, which is the organic psychosis, which is fully immersive type of psychosis, in which we have a form of brain damage. And this is something that often occurs in patients who have intensive care unit hospitalizations, and have severe organic syndromes in which they have a form of multi-organ failure, and they have problems that are probably arrive to the brain due to a toxic metabolic process that alters brain function completely. And we know that these are patients who enter a form of complete disruption of sleep-wake rhythms, and so they tend to have a complete fusion across the states of wakefulness and sleeping, and are fully immersed in a multimodal hallucinatory experience. So if you have access to psychotic patients through the delirium condition, you will see the patient as a fully delusional and hallucinated patient who closely resembles the experience of dreaming. Unfortunately, most of these patients are severely amnesic when they recover from the delirious state, and are hardly able to describe the experience very well. But this, you see, is not always the case. It's very difficult to experimentally frame delirium from this point of view, but this is not always the case. And some patients are able, when they acquire a normal physiological brain activity, to describe what they have experienced. And this often seems like being stuck in a continuous form of dreaming. But of course, we have different types of psychosis that are not related to neurological, organic underlying conditions. And these are more difficult to understand in terms of what causes them and what determines them biologically, but they do have the same type of, they can have the same type of intense psychotic experience. For example, brief psychotic disorders or postpartum psychosis, as we will see in a second, are experiences that occur very rapidly, and they tend to have a rapid onset and a rapid offset, and the patient tends to be highly immersed in the experience and then to develop an adequate insight slowly after exiting the experience. These, as delirium, these types of experiences are very difficult to study experimentally, because the patients usually experience a very intense form of psychosis, and so they are the type of patients that it's difficult, as we were saying, to place in a brain scanner, to study with an EEG, to experimentally ask to comply with a task, etc. So postpartum psychosis is another good example. You see here a description from a patient who had a postpartum psychosis, which had a very rapid onset, and this was diagnosed within 14 days of giving birth in a woman who had previously had no psychotic experience, and she described a sudden hallucination that prompted her to drive to the wall at high speed before her husband could take control of the car and bring it to a halt. So see, the rapidity of onset of the experience appears to make it more immersive. The patient is more prone to act on the experience if it is something that is occurring abruptly in the context of an otherwise healthy brain. So you see, the patient's subjectivity here is that I started with hallucinations or bad dreams. I'm not sure what it was. She cannot describe the difference clearly of what was going on. The ones who observed her and decided to treat her were observing externally some experience that is clearly frameable as a hallucination, but she could not really distinguish it from the experience of a bad dream. So 3/4 of patients do report sleep disturbances before the onset of persecutory delusions. And one of the areas for future inquiry is certainly the understanding of what the mechanisms are, and if there are disruptions in sleep-wake rhythms and oscillatory brain activity occurring during sleep and wakefulness just before the experience of a psychotic outbreak. And we're only actually beginning to look at this in terms of research at the moment. So for my last slide, I would like to leave this open for discussion. And my thinking on this at the moment is, does time count? So is the difference in immersivity between the dream experience, which is fully immersive and detached from the environment, and wakefulness in healthy subjects, which is a full interaction with the environment and a partial immersivity in your internal thoughts and your fantasies. But this is only limited because we are continuously interacting with the environment. Is this related to a very, very sophisticated circadian timing of an internal generator, which actually allows our brain to physiologically enter a dream state and physiologically exit from that dream state? Because if this timing is central and this timing somehow dictates our circadian oscillation from full immersivity to partial immersivity in our internal world, this might be the reason why in psychotic subjects we find it difficult to clearly identify the similarity between dreaming and psychosis from an experimental point of view, because we're attempting to study it in patients with schizophrenia, who are patients that tend to have a very sluggish onset of psychosis, a very slow onset of psychosis occurring during the early childhood, adolescence, until the outbreak in young adulthood. And this could be the reason why they have a form of adaptation to the psychotic experience, which makes it naturally partially immersive and only continuously understood in interaction with the environment. Because on the contrary, if you go to extreme forms of abrupt, rapid onset psychosis, such as delirium and toxic psychosis, or as we've seen, brief psychosis or postpartum psychosis, we do have an aspect which is more closely related to a full form of immersivity, which is very, very akin to the experience of dreaming. Okay, so this is my last slide. I hope it can be of use for discussion. Thanks to everybody.
Thank you very much, Armando, for a marvelously lucid discussion of the topic. I'm betting that there are quite a number of questions out there. We have 20 minutes or so.
Okay.
And now, colleagues, is your chance. You just indicate with a raised virtual hand, or indeed a raised digital hand, that would be great. Let me kick off with a dilettantes question then, Armando, coming from an almost entirely humanities background. I'm very intrigued, coming from a literary perspective, by the problem of the reportability of dreams, which you've encountered in various ingenious ways, I have to say. I was just wondering, really from the point of view of someone who's studied literary dreams quite a lot, whether the question of the reportability of dreams, whatever about the wonderful typologies that you were, and taxonomies that you were establishing in your paper, whether the question of whether people can report their dreams, irrespective of the difference between hallucination and sleep, and so on and so forth, and so on and so forth, might be related to whatever artistic talent is. By artistic talent, I mean a kind of twin set of, now in my language, twin set of competencies. On the one hand, all of that stuff for manipulating articulate language, which we call rhetoric and poetics and so on and so forth. Grammar too, Schleiermacher would have insisted. But on the other hand, also non-pragmatic skills, that thing which people think of as innate artistic talent, imagination, something like that. By which I mean the porosity between the conscious domain, the unconscious domain, and possibly what Kate Hales might call the non-conscious domain. The ability in some way to mediate between those at a pre-linguistic level, and how that might be described in proper scientific terminology.
Well, that is a great question, and it's clearly one of the topics that has to be addressed when you attempt to study the cognitive construction of a dream report. And of course, this is I would say we would have two answers: one for what we consider a healthy subjects without a mental disorder, and one for a subject who has a mental disorder, because of course the latter has, if you're considering a patient with schizophrenia, you also have neuropsychological deficits, and you can have a cognitive impairment in these patients. And so the ability of the patient to construct the experience verbally must be considered limited, and this is limited by the pre-existing deficits. And of course, if the person is verbally unable to completely report his experience, it remains unclear if this is associated to the unreportability of the experience itself, or to the verbal ability to express that experience. So we attempted to, when we approach this from this point of view, to somehow standardize for example, word count, which is something that emerges quite clearly in dream research as something that has to be clearly addressed to preliminarily before you attempt to do any form of analysis on dream content or dream or formal aspects of dreams, because the word count is fundamental, and this is very intersubjectively, it varies intersubjectively. So you have to standardize for the word count. And this is, I understand, I mean, I can see it is a very rough-grained attempt to approach the complexity of the pragmatics and of the several different levels of variability that you can have across individuals. But this is something that emerges quite clearly from dream research as something to check for, that is not so easy to find other types of research that have addressed in much detail which other aspects you would want to address. But this would probably be something very interesting for future research. And going back to the healthy individuals, this is where I would start from. You would need to certainly assess pragmatic abilities with some form of, I would say, control task, by asking the person to narrate another form of experience, and then attempt to standardize a dream experience on the basis of that individual's ability. But if you look at the other point, that is the pre-verbal, I think this is a term you used. I'm sorry if I'm vague on some of the expressions, but I'm sure you know this is not my field. But the pre-verbal experiences, such as artistic experiences, such as imagination, etc. This is another highly interesting topic, because we have there's been a recent study from another group that showed something that is called aphantasia, which is the lack of ability to produce fantastic story, is correlated with a reduced ability to experience dreams. So these are two aspects that do really seem to go as if they have a common generator. So we have ability to have vivid experiences, vivid artistic, imaginative experiences that is variable across individuals, and individuals who have more elaborate, fantastic fantasy experiences and more vivid imaginative experiences do tend to have more elaborate dream experiences.
Thanks very much. I better not pursue that. I've got something like a question from Marco, which has appeared on the chat. Now, Ronan, can you perhaps unmute Marco, or Marco, can you unmute yourself? Feel free to contribute live.
Can you hear me now?
Yes.
Yes.
Oh, hi Armando, good to see you. Hope everything is all in all is okay in Milan. We are not that far away. So my question is, I put it in the chat, but I was wondering whether, given your stress on the experientiality of the dream, I was wondering whether experientiality is also quite a specific term in narrative theory, but we can discuss this in another situation. But I was wondering whether you think we can redefine or reconceptualize bizarreness in experiential terms, by which I mean, and I was making an example in the chat, like sometimes in a dream, we see a scene or an agent or an element that is, if described, is nothing like illogical or paradoxical or impossible, but still experientially, when you are in the dream state, it feels strange. So it is, and this is, and as I was saying, this is something that also people with hallucinations, as you know, do report, the feeling that even if there is nothing impossible, they are not having visions of anything speaking or flying objects or anything like that, but they still feel that there is something off or strange in an object or a person. And so I was wondering, this to me feels like some kind of experientially experienced bizarreness rather than something more on the logical level, which is where Hobson and the others are usually going.
Yes. I fully agree, Marco. Thank you very much for the question. It's this is something that I've been giving some thinking for, and I totally agree that we could, and I totally agree that logical, let's say the cognitive, this is the term that we use, bizarreness from the Harvard group, is somewhat limiting, and it has an element of confusion as well, because if you look at the scale, it has the emotional bizarreness as well, which is you tend to, I would say, the example you gave would be a subtype of bizarreness that you do score with the Harvard scale, but it is it's actually more akin to what you are saying. It's an experiential bizarreness, because it would be called an emotional bizarreness, but it doesn't make full sense with its inclusion in the cognitive construct of bizarreness. So this is absolutely true. I have given some thought to this quite recently, but my question would be, if coming from your experience on hallucinations and how patients would report this type of hallucinations, would you be thinking of a qualitative type of analysis or a quantitative type of analysis?
That is interesting, because in a way, I think before we need to agree on which kind of concept of bizarreness we want to explore, because in a way, I think with hallucinations, we certainly reached the point of considering the importance of this kind of bizarreness is always relational, I would say. So it's a relation between the experiencer and the world, or the elements, any kind of elements, even a relation between thoughts and the experience. So sometimes it's really, if we stick to the relational definition of hallucination, where the hallucination is happening between the experiencer and the world, in that case, I think you probably can come up even with a form of coding, which is for quantitative data that will reveal different things. But certainly the phenomenological felt quality needs to go through a qualitative analysis. But I think the same could apply to dreams as well.
I agree, and my question was also because I'm not sure if we've previously discussed of the work of Joseph Parnas. He is a Danish phenomenologist, and he developed this possibly the most elaborate but also validated coding structure for experiential material, which would be the examination of a nominal self-experience. And he was actually very aggressive towards the concept of bizarreness, not the one we employed in dream research, but in general to the Diagnostic and Statistical Manual, the DSM, American Psychiatric Association model of bizarreness. He actually obtained it to be removed as a qualifier of schizophrenic experiences, because it was bound to the content of the experience, and he showed with a beautiful study that this could not be easily defined. If you ask 3 people what is bizarre in terms of a content, they are unable to say so in the same way if you ask 3 raters. So that in that somewhere along that scale, and they have another one now that I haven't looked into, which is the examination of anomalous world experience. I think you can possibly find something that is very, very clearly related to the experience you mentioned on hallucinatory, the strangeness and bizarreness of the hallucinatory experience, and that might be we might be able to bridge to the experience of dreaming. Because
I think that's a great point, and also we can discuss later. But in the project, in the Voice, there was the Parnas and Louis Sass.
Marco, can you be very brief, please? Because we've got 2 people. We've only 6 or 7 minutes left, and
sorry, Nick, and thanks, Armando. Apologies.
Okay.
Sorry, Marco. Sorry, Armando.
No, you're right.
I've got Rob Barton, who's been patiently waiting now, and Ellie Hemingway, I think, would like to come in as well. So if these could be unmuted as well, Ronan, if they can't do that themselves.
Can you hear me okay?
Yes.
Rob first.
Okay, thanks. Thanks for a very interesting talk, Armando. During this project, one of the things that I've been kind of wrestling with is the distinction between the dream experience and the report. My question is about maybe focusing on the process of waking, recalling and reporting dreams as being a constructive process. And to put it in a nutshell, I suppose my question is, how much of the content and structure of a dream do you think is a product of that process rather than intrinsic to the moment of experience while dreaming? And is it an interesting thing that we should, instead of treating the sort of recall as a bit of a nuisance that gets in the way of understanding what really happened in the dream, would it actually be interesting to focus more on the process or the processes of recalling and reporting as constructive processes that construct narratives and so on?
Thank you. This is also another very, very important aspect. Of course, I think we might want to look into the work of Mark Blagrove from Swansea University, who's done a bit of research on this. He also studied what he calls the dream lag effect, which is how much enters the dream from previous days and how much is reported in the content, depending on the moment in which the report is done. But most specifically, there is some evidence that this varies considerably depending on the time of the report. So the answer would be that the longer the time from the experience to the report, the more the content and structure are influenced by the waking experience. But there is almost, I would say, unequivocal evidence that if you, for example, when I mentioned Francesca Sicleri's work, when you have a multiple waking paradigm in research, and you have a subject sleeping in the lab, and you awaken them several times during the night across different stages and ask them for the experience, you have possibly the closest relationship with the actual experience in the report. And you see that dreams tend to be a little less elaborate. They tend to be a little less structurally bizarre than you would find if you have a morning report. So we previously thought this was because you have REM sleep in the latter part of the night, closer to the awakening, and this is where the most vivid dreams are. Possibly this is partially true, but it's also that more time is more waking-like cognitive processes are going on from the experience, and this enters in the structure and content of the dreams. And so that would be my answer. You would have to keep very strict protocols, and I'm not sure if someone has yet designed a study in which you do both in the same types of subjects. So you ask for the reports to be confirmed, for example, after 1 day, after 2 days, after 3 days, and see how these vary in the same subjects. That might be a great way to approach this topic. But I would say time is important in that case also. And
okay. Time is important, but Ellie Hemingway, I think you've got 4 or 5 minutes to put your question, please.
Yeah, I could have asked 100 questions. That was so interesting. But one thing I'm really curious about, as well as my research at Durham, I also work with people clinically as a different job. So I was really curious about the role of sleep deprivation and whether experimentally that could be one way to understand more. So, for example, we know that if you keep a healthy control awake, for a period of time, they will go into a psychotic state at healthy control. And also when people have had a one-off, a stress-induced psychotic episode with no underlying condition, very often sleep deprivation seems to be a major part of that, and a sleep routine after the episode is essential to relapse. But that's not the case with schizophrenia necessarily. Sleep deprivation doesn't seem to play a role. So I was really curious, because that could be quite a sort of a thing to study, to understand what's happening in the brain. So I don't necessarily mean sleep deprivation, I mean being awake for hours on end seems to induce psychosis. So why is it different? Why does that happen in some conditions and not others, and what's going on in the brain? So
well, this is a wonderful question, and it's something that of course we don't have a clear answer to, but I would say I've looked into sleep deprivation quite a bit in mood disorders, because we do therapeutic sleep deprivation. We do total sleep deprivation for patients with depression at the clinic, and of course when we do a trial of this, the only major exclusion criterion is the presence of psychotic symptoms. So you don't want to do a sleep deprivation in a depressed patient with psychosis. You want to do it with a depressed patient who does not have psychosis because of what you were describing. My take on this is that we have two different types of if you take it from the point of insomnia, and you think of two different types of insomnia. One is a reduced need for sleep. One is reduced ability to sleep. If you conceptualize insomnia and the lack of sleep in these two ways, patients who have a reduced need to sleep are likely to have a compensation, and they are likely to have a compensation that probably, this is not very well understood in neurophysiological terms, but probably has to do with the synaptic plasticity that is missing when you deprive a person from sleep. And what seems to be very important for the antidepressant effect is the activation of neurotransmission that is dependent on the on what is missing from the slow wave part of the night, and you have a suppression of the required slow wave activity, and then this secondarily boosts neurotransmission. And this is something that is possibly the core to understand why some people have a pressure to sleep, because they have a need to sleep and they experience it subjectively as a need to sleep, but maybe have an insomnia or cannot have other mechanisms acting that are limiting their ability to sleep. And other people have a reduced need. And this would be, for example, a patient with a manic psychosis,
Yeah.
or a patient with schizophrenia who actually just does not sleep and can go for days on end without experiencing the need for sleep, and not experiencing it as a clinical problem that he takes to the clinician. But I would say this would be the aspect I would look into to understand this difference.
Thank you.
Okay. I'm afraid we really don't have time to take any more questions. Heather wanted to have a quick one, I'm afraid, but sorry, Heather. We have to observe our time limits, but I'm sure Armando will be available.
Oh, of course, I can
to talk bilaterally afterwards. Thanks,
yes.
Armando, and thanks not only for your most wonderfully lucid and articulate paper, but also for your most wonderfully lucid and articulate answers.